the audience at home that you can use the chat function to ask any questions, and Gareth and I will try to prompt our speakers. So,
nope, somebody in the chat now? I'll just start off with one for Berkeley. So I think that diet study is fascinating, and most fascinating was where you showed they showed difference was in terms really maybe in palatability, because people felt better, they slept better, kind of health-related quality of life was better. And clearly, as you alluded to, the specific carbohydrate diet is a little more restrictive, more difficult, and for years we've been telling people be on a low-fiber diet. So you think that's going to play out in clinical practice for you now?
That's a great question. Thank you very much. So interestingly, prior to this study, I would actually already been using the Mediterranean diet as a prototypical kind of healthy diet. My hypothesis is that it's not necessarily a diet per se that actually drives the benefits from symptom standpoint as well as inflammation standpoint in Crohn's disease, but it's actually more the constituents that all together that is mostly composed in a plant-based diet. So even prior to the initiation of this clinical trial, the suspicion was already that there was actually no difference. And so in practice, it does indeed actually have a role in practice. And in terms of the fiber, although they did not find great detriment with the use of these plant-based diets in Crohn's disease, I would still exercise a bit of caution in those who are found to have stricturing disease. So there's some nuance that needs to be had in clinical practice, although these data show that in general there was not much of a difference.
Great, thank you. We have one question in the audience here.
Thank you for your talk. Hello. Thank you for your talk. From San Diego, I had a question for Dr. Hall. One of the studies that you presented that I'm most interested in had a group of patients in the target to treat that had their dose of the ustekinumab decreased to Q4 weeks. But then you also mentioned that there was questionable guidelines or suggestions in terms of checking levels to guide that. So in your clinical practice, how often do you need to decrease the dose, and what kind of things do you use to help you make that decision?
Yeah, that's a great question. And it's tricky to kind of glean clinical pearls from this treat to target Stardust trial, because it doesn't necessarily mirror what we do in clinical practice. We don't do a Q12-week dosing. We don't typically recommend a 16-week colonoscopy at 16 weeks. What we do know from the post hoc data from the trials, as well as additional data that's gathered, that it's very important for patients to get the first infusion and then the first maintenance injection at Q8 weeks. So I don't make any treatment adjustments until they've received that first maintenance dose. And then kind of gleaning from what Berkeley was alluding to, I use biomarkers and as well as our clinical symptoms, and I look at week 12, which is what is recommended at treat to target. But in terms of what I follow what's abnormal at baseline. So if it may not necessarily be the C-reactive protein, because not everybody mounts a C-reactive protein, it may not necessarily be the calprotectin, because people, especially with small bowel Crohn's disease, may not have a robust fecal calprotectin, but it's whatever is abnormal. Can I get them down on steroids? Is their hemoglobin corrected? Is their albumin improving? Is there some sort of a meaningful delta? And my gauge is usually I want to see at least a 50% improvement. If I don't do that, then I ask about, okay, is this mechanism working? So did they have some sort of symptomatic improvement after the infusion? For those patients, I would then either discuss increasing the dose to every 4 weeks, or potentially off-label, this is not per package insert, or potentially giving them another induction infusion. However, I don't necessarily always check levels. I think that the data for ustekinumab and vedolizumab for therapeutic drug monitoring is a lot more controversial because it's less robust than infliximab, which has clear peaks and troughs. Ustekinumab and vedolizumab, the pharmacokinetics aren't strictly a peak and trough, so don't restrict yourself based on, okay, their level is 4.2, and I want them to be greater. If they really had no response to infusion, they're probably a primary non-responder. The key take-home message from Stardust was actually that most patients did not need every 4-week dosing, and we're probably dose escalating too much for patients who are probably primary non-responders.
Thank you.
I think the, other questions? No. The increasing number of head-to-head clinical trials in IBD and elsewhere in GI, hopefully, is really, really important and fascinating. So with the ustekinumab and adalimumab study, equivalent efficacy and you mentioned some factors that might cause one to choose one or the other in practice. Are you modeling this and doing a cost-effectiveness analysis that takes into account differences in adherence that might be attributable to the 2-week versus 2-month, and then the cost of the drugs?
Yeah, those studies are certainly underway. The wrench in that is adalimumab is going to be available as biosimilars. They are available in Europe already as biosimilars. And as more and more mechanisms of action become available, that will drive some of the costs down. But certainly, what this study does show that is that pricing, insurance-related preferences actually do matter when we talk about what should be our first-line agent. So as a first-line agent, I think that this study is reassuring to tell our patients you have multiple options, and they're not only safe, they're effective. And so you have to choose the regimen that's not only safe and effective, but also will be preferentially covered through their insurance, particularly first. The steroid-free clinical remission rates at week 48 were pretty staggering for both, so they're both good agents.
So before we move on to the next section, just modern technology, we have a question from the audience, but I'm going to put a little twist on it. The question was, can you use fecal calprotectin as a screening test? But my question kind of would be, how do you use it? How do you both use it in practice?
I'll let Berkeley go first.
Well, yeah, so great question. So I actually would advise against using the fecal calprotectin as a screen test. I've interestingly found fecal calprotectin to be positive in some individuals, even without the presence of inflammation. And as you may recall from the data that we had provided, that there was only its use in and its correlation with the endoscopic as well as histologic inflammation was actually quite modest. This accuracy was roughly between 60 to 77 or 78%. So from that standpoint, using it as a singular tool is probably not accurate or sensitive or specific enough as that tool. From the standpoint of its use in practice, I actually often use it as a surrogate marker. So Tina just mentioned earlier about looking at baseline markers of kind of inflammation or disease activity and health status, and using those similar markers to kind of monitor improvement or response to therapy. So I actually also very similarly use that as a tool. And sometimes to also kind of decrease the colonoscopy burden, not to say that they don't undergo the colonoscopy for eventual confirmation or diagnostic evaluation as needed, but to actually kind of stretch it out a little bit further and use that as an interval tool for assessing response to therapy, monitoring, whether they are actually on a positive trajectory or not really responding to any disease, to the medications themselves. Because we also do know that symptoms and inflammation do not necessarily correlate very well with each other. And so even though they may have actually a lot of symptoms after the initiation of therapy, their inflammation internally may actually be improving. And we can also say that from what was actually found with that DINE-CD, that diet study.
And just as a one last follow-up to that is, remember, it's just a marker of inflammation in the colon. So anything that causes inflammation in the colon will cause an increase in calprotectin. The best use in clinical practice is when you combine it in ulcerative colitis with a stool frequency score of 0 and 1, and a rectal bleeding score of 0, and a fecal cal less than 50. That correlates the most closely to endoscopic remission. Otherwise, very tough.
Great, thank you both so much.
Thank you.
And now I'd like to move on to the next section. I want to welcome our state-of-the-art speaker, Dr. John Pandolfino from Northwestern University. He's a world-renowned expert in esophageal